gerontology, and palliative care. Now we're recording. So Maile, just a couple of questions for you before you start. Can you tell the group about what your best last vacation was?
Well, my best last vacation was probably our family trip to Joshua Tree. It's the first time my kids were there. And of course, both of my children were annoyed in the beginning, but as but as soon as we got to our first giant boulder, that was it. And they were in love with Joshua Tree and they wanted to keep going. I didn't think my 7-year-old was going to make the 1.5 mile flat trek because she usually complains after walking more than 2 blocks, but she did it and she wanted to do more. So that was just a really awesome trip for us.
All right, very good. You know what? I'm going to just turn it over to you now to get started.
So thanks, Jill. I think for those of you who don't know who I am, I'm also a Owen Clinic provider. I'm one of the co-directors of our Center for AIDS Research Clinical Investigations course. So if any of you are interested in clinical research here in San Diego, but don't have the infrastructure, would love to talk more about it, please get a hold of me. We offer consultations for free and we'd love to help you get meaningful research done. But my primary research interest really is in aging with HIV, and a lot of that has to do with Stephen Karpiak. So I really wanted to dedicate this talk today to him. He passed a couple of months ago, and for me, Steve was one of the first persons that I met that was a modern advocate researcher. So, I know a lot of HIV researchers got into HIV research because of the advocacy, because they wanted to do more for their patients. But there's less of those now. And Steve started that way and has always been that way. He gave me the courage to pursue research questions, that I was seeing my patients struggle with and not just follow the NIH priorities. And and I'll be thankful for him for that. But this quote for the talk, living with HIV is aging with HIV, is actually a quote that Steve shared with me from one of his ROA participants. Steve was doing HIV and aging research a decade before anyone else was actually interested in it. So, truly he's a pioneer in this field, and he's always centered it on people who are experiencing HIV. So, the second aspect or the second part of this quote was, people are living with HIV, are aging with HIV, which means everybody should care about it. This is not just something that people who care for older adults or older adults living with HIV should be worried about. So I have a couple of disclosures. Oh, it's not working. I'll just use this. So I do have research findings to the institution from both Gilead Sciences and ViiV Healthcare, but I am not going to be talking about any antiretroviral therapy specifically today. Well, I will be, but just not making any recommendations. So, a lot of people start HIV and aging talks with this graph because it's just really interesting. So this is from a Kaiser study looking at people with and without HIV. And it shows that over the decades, we really are closing the lifespan gap. So it used to be about 20 years difference survival rate for people with and without HIV. And now we're somewhere closer to 8 or 7. And that's actually cause for celebration. But, Steve Karpiak recently also showed this slide a couple of weeks ago and said, in his mind, how he interprets this is that we're not there yet. Certainly we're closing the gap, but from about in the last, decade or so, we really have not made that much progress. So there's still a lot of work to be done in improving the lifespan of people with HIV. But an area where we truly have made no progress is that we have not been able to close the comorbidity gap at all. So people living with HIV still are experiencing more and earlier comorbidities than people without HIV, and from the beginning and persists. So that is, I think, an area that our field really needs to be focusing on. And besides all of the excess comorbidity, physical function impairments are very, very common in people living with HIV. And this cohort had a median age of about 51 years. So this is a younger cohort. This is not people in their 70s. About 40% of folks had demonstrated that they had some physical impairment. So that's a really high percentage of people that were struggling to function in their day-to-day life. Now, we do know that certain populations of people living with HIV, so if you're older, if you are of a Black race, if you had a greater body mass index, and if you reported being very inactive, you are more likely to have physical function impairments. Other aspects that were associated with physical function impairment, and specifically frailty, were depression and hypertension. I think we also have some new-ish data. So for a while, although we knew that HIV was associated with neurocognitive disease, we didn't know whether or not people with HIV were going to be experiencing more neurocognitive impairment as they aged. And that's primarily because the cohort was younger. But now that we have people who are in their 70s and 80s and 90s, we are beginning to see some age-associated conditions. And this study that looks at Medicare beneficiaries was probably one of the first studies that actually identified that people living with HIV do have a higher prevalence of Alzheimer's and other related dementias than people without HIV. Granted, this signal was not observed until people were about 80 years old. So this is not something that is affecting our 50s and 60s years old, but it is something that's there and something that we need to try to figure out why, like what is causing this enhanced prevalence. Women, unfortunately, like many things, we're also more likely to experience Alzheimer's or other dementias than men. Another study, also recently published, looked at the risk of neurocognitive impairment in younger versus older people with HIV, and indeed found that older people with HIV were 83% more likely to have neurocognitive impairment. So this is definitely something that we're seeing is progressing or worsening with age. Older people with HIV were also more likely to worsen in neurocognitive impairment over time than younger persons. And again, we see it differentially impacting certain populations. So like non-white ethnicity was associated with greater cognitive impairment, abnormal creatinine, so kidney dysfunction, having a detectable viral load were all associated with this. In work out of here, so Ron Ellis looked to see like what is associated with the development of neurocognitive impairment in people with HIV, and really it looks like it's these comorbidities. So it's these comorbidities that we have been unable to impact over time that do seem to be contributing to cognitive impairment. The Charlson Comorbidity Index score, for those of you who are not familiar, right here at the top is a composite score of a whole bunch of different comorbidities, and clearly that is highly associated with impaired cognition. Okay, so I was trying to figure out how to talk about aging with HIV, and I came across this really cool article by Monty Montano that looked at kind of like a scale. So geroprotectors versus gerodrivers. What geroprotectors are things, activities, compounds that actually enhance the lifespan, and gerodrivers are behaviors, harms, and activities that decrease the lifespan. So as you can see, of the gerodrivers, macromolecular damage, cellular senescence, inflammation, and stem cell exhaustion are all characteristics of HIV. So HIV itself, unfortunately, is tipping the scale for people living with HIV to have accelerated and accentuated aging, because it itself impacts a lot of these pathways of gerodriving. And how does it do that? So this is another great article, really trying to break down how different aspects of living with HIV contribute to accelerated and accentuated aging. And it does so through multiple mechanisms. I'm going to go into more detail through this talk about these different mechanisms, but ART and PrEP toxicity is contributing to this. The viral reservoir, or like the ongoing replication of HIV that we can't quite get rid of because it integrates into the CD4 T cells, co-infections like hepatitis C, and then the microbiome and the impaired gut integrity. We'll talk a little bit about that as well. But on the other side, other factors such as stress and trauma and depression contribute, chronologic age, socioeconomics or lack of socioeconomics, and lifestyle. So, there are definitely biologic aspects of HIV that are affecting aging, but there are also psychosocial aspects. Some of these factors cannot be changed. So chronologic age can't change your age. Like we haven't figured out how to do that yet. I'm sure we will at some point in our human existence, but right now you are as old as you are, and that is your age. But there are some things that we certainly can impact. So stress, trauma, and depression, lifestyle are things that could potentially be very modifiable. And then there's some things that maybe we can do some, but not all. And, in that, I also put socioeconomics, so health disparities. I believe that we are able to impact health disparities in our country. It's just whether or not we're going to have the will to do it. We can do it. Just whether or not will we do it is the question. But on the other side of things, yes, maybe we can impact some of these ART toxicities. Maybe we can affect the viral reservoir. Maybe we can impact our co-infections. And then I put a question mark by microbiome gut integrity, because I think that as we'll discuss in a little bit, that's still up in the air. We don't quite know yet if we can dramatically affect that. So let's start with ART toxicity. So things that we cannot change are historical exposure to ART. Like we can't go back in history and put our patients on different medications, or start them earlier, or do all the things that we do now. That's not possible. So some of the, certainly I would say many of our long-term survivors, or most of our long-term survivors, are here today because of historical ART, and I'm so thankful that we had it. But there has been some cost of that. So some non-modifiable things, at least so far, neuropathy, is secondary to mitochondrial toxicity from some of our older D drugs. That does not seem to be easily modified. A lot of folks are really struggling with that. Avascular necrosis, the damage of the bone is dead. We cannot bring that back. We can certainly do things to help people cope better, have less pain, and be more functional, but we are unable to build that bone back. There's some partially modifiable costs of ART toxicity, like lipodystrophy, like tesamorelin can help with that. Bone demineralization, we have medicines also that can help with that. And then there are some completely modifiable conditions, just take away the drug. So, if someone's on a protease inhibitor and they're experiencing a lot of dyslipidemia, maybe withdrawing that will help improve that. Similarly with Fanconi syndrome associated with tenofovir, removing the drug resolves that condition. So maybe we can modify some historical things, maybe we cannot. But we can impact new exposure to antiretroviral therapy. And, we know a lot of the side effects of all of the medications that we have, and we learn more and more about it as time goes by. And although we have fantastic guidelines for HIV care, I'm encouraging us to really consider personalizing again, at least for older adults who may be experiencing other comorbidities. So for example, if you have someone who is experiencing a lot of weight gains, maybe we need to think about, like, should we continue them on their TAF? Should we continue them on their INSTIs? If they have a cardiovascular risk, do we want to continue them on a baclofen or boosted PIs? So that's one of the things I wanted to kind of open to discussion today. I wanted to see what people feel or thought about, personalizing new antiretroviral therapy based on individuals' risks and comorbidities. What do people think about that? Should we be like, nah, let's just stick with the guidelines, or not? Dan? No, oh.
Yeah. So I don't know, is this on? Yep.
Yeah.
Okay. Yeah. So Maile, I absolutely agree that I think it is worthwhile to certainly personalize. I mean, the guidelines, I've always I kind of joke that the guidelines are for people who don't take care of HIV. And for those who do take care of HIV, then, we obviously then individualize and kind of personalize based on our own experience. And so I absolutely agree. I think we do need to personalize, and that's the challenge with medicine, is it's not ever a single, the same thing does not work for every individual. So definitely individualize.
Anyone have other thoughts?
Oh, no, you're leaving. Oh, no, it's here.
No, I just wanted to say I agree with Dan. I think it's something we've always tried to do. And to his point, I think for those that do take care of people living with HIV, this has been a priority, I think, ever since we've been, had so many different options now for antiretroviral therapy. And I think we should be thankful that we do have so many options that we can individualize therapy for people. But also keeping in mind that usually there's always trade-offs. There are reasons that our first line regimens are first line, and they have such excellent characteristics that it does fit a lot of people, but I think like both of you are saying, it's not for everybody. And I think we also get into a bit of an inertia from pharmaceutical companies and everyone that's trying to push their regimen to be the go-to regimen. And I think when we listen to talks and things like that, we always have to keep in mind that we do have all these options for a reason, and we can hopefully choose what's right for each individual patient. So.
Yeah. Okay, so now I'm going to have more discussion. So I'm not going to make a recommendation here, but I don't know how controversial this is, but if indeed antiretroviral therapy toxicities is contributing to some degree, at least, the accelerated or accentuated aging that our patients are experiencing, like, is 2 drugs better than 3? So, people living with HIV, this study I think is really interesting. So they followed people with HIV who suppressed on 3 drugs, and then they randomized them to either continue on their regimen or transition to a 2-drug therapy. And then they followed them out for 8 years, which is longer than any of the 2-drug studies have gone out. And they found no differences in low-level viremia. They found no differences in serious non-AIDS events. But what they did find, and I'm sorry that these slides are so small, but if you look at the two drug regimens, which they did 2-drug PI and 2-drug dolutegravir, it's either red or green. Over time, with many of these common inflammatory markers that have been associated with comorbidities, we're starting to see them veer off from the black line, which is the 3-drug therapy line. So whether or not these differences over time are actually clinically significant, we don't know. Whether or not going out 20 years from here, we're going to continue to see things, we don't know. But this, I think, I just want to give this information to everybody so people are aware, and when they're having conversations with, like, their patients and they're switching them, they can communicate, hey, there's some things we still don't know yet. Like, unfortunately, we all know from the history of antiretroviral therapy, lots of things come out years after drugs are approved, our first-line therapy, like, and this is a little worrisome to me. That being said, I would not discourage someone from Cabenuva or the injectable drugs per se, because for folks that my patients that have switched over have told me that it has significantly positively impacted the stigma that they experience, the internalized stigma. So I'm not saying, like, we need to tell all our Cabenuva patients, hey, you got to go back to 3-drug therapy. I think there are some benefits from different modalities of medications, that people are experiencing that may benefit them more than a potential future outcome. But this is just something I want people to be aware of. This study I found incredibly interesting. Any thoughts, comments about this?
You ruined the chair.
I ruined the chair. Yeah, it's on. Yeah, it's a great question, and I think for me the answer depends on what the patient wants to do.
Yeah.
I mean, I think for many of us who practice probably more patient-centered care, and I think it's because the evidence is fairly similar in terms of either regimen. But for me, I find that the patients who are, some really want to do the 2-drug, and some are scared of doing 2 drugs. Yeah. And I think whatever regimen they're most comfortable with is what we go with. For some, that's, a desire to switch to an injectable regimen. For some, it's, staying on their old regimen until it, gets off the market. So that's what I would say.
Yeah, I have some patients I can't get off Atripla, like, still to this day. And I will also reiterate that the injectables were not part of this study. So whether or not they're different in one way or another, we don't know. Okay. So I can't not talk about art toxicity without briefly mentioning polypharmacy. So, I think now that our folks are aging and accumulating these comorbid conditions, they are unfortunately needing to have more and more medications beyond their antiretroviral therapy. And as our bodies change and age, so does the effect of different medications on our bodies. So at some point, there are some people that it is probably inappropriate for us to be giving them certain types of medications. And I'll have a slide next, which shows the one medication that I think we really should never be prescribing to older adults in general. But really, I think there has been a new syndemic that has been identified by Amy Justice that really looks at the combination of aging, HIV, polypharmacy, and substance use. So those three things, when together, seem to significantly negatively impact quality of life, physical activity, cognition, falls, frailty, mortality, a whole bunch of negative outcomes. And we should be very much focusing on minimizing polypharmacy and substance use because those are things that we can modify. Can't really change people as they're aging. But this is, I think, a emerging syndemic that we are going to see more and more consequences of. So one study out of Croy, the anticholinergics. So I think this is already, anticholinergics in older adults has already been demonstrated to have all sorts of negative outcomes, but we really haven't studied it much in HIV. If you look here at this commonest anticholinergic medications prescribed table, I'm sure many of you can see meds that like a lot of our older adults are taking and some that we prescribe regularly. And what they did in this study is they really wanted to say, hey, what is happening for older adults without HIV is also true for our folks. And they found that people who are prescribed anticholinergic medications, whether it's one or more, were more likely to fall and were recurrently, not just one time, and were more likely to experience or develop frailty. So, I mean, I think that a lot of these medications are PRN. There's some of these that are antidepressants that I think may still be beneficial, but maybe we should also, like work with our psychiatry colleagues to help better understand, can we pick something that is maybe safer for older adults to diminish those risks to them? And so that's all I'm going to say about polypharmacy. So the next three aspects, or the next way that HIV affects aging or serves as a gerodriver is via inflammation. And it does inflammation through multiple pathways. So the HIV reservoir, co-infection, and gut translocation. And I'm going to just briefly talk about those three. So why does inflammation matter? I think most of the people at this conference are aware that inflammation predicts mortality and morbidity in people with HIV. While inflammation or immune activation decreases over time when people are taking antiretroviral therapy, it doesn't ever go back to normal. And I think we first became aware that inflammation was a thing for people with HIV with the SMART and the START studies. So when we were evaluating, is it feasible to give people drug holidays? Like, can we do this strategy to kind of, when ART was more toxic, to kind of help people not experience so many toxicities and help them to adhere to their meds? And then the START study is it better to start them earlier, or do we wait until they have some immunosuppression? In both of those studies, they found, SMART was actually discontinued early because they found higher mortality and morbidity in people who were doing the treatment interruptions and people who were starting later in their antiretroviral therapy treatment. And all of that was associated with inflammation. So IL-6, CRP, D-dimer, these are inflammatory cytokines that you're going to see again and again in this talk, are associated, and we're able to predict the higher mortality and cardiovascular disease events that people were experiencing. And since then, these inflammatory markers have been associated with a whole slew of other conditions: thromboembolic disease, strokes, type 2 diabetes, neurocognitive dysfunction, and frailty. So inflammation is bad. And how do we modify inflammation? So I already told you, that it persists over time, even if people become undetectable. And so one way I think that we can is we can start people early. I think most people do this now. I don't think people wait anymore to start people on meds. And now there's this movement for immediate antiretroviral therapy. You get diagnosed, you get into a clinic, and you get antiretroviral therapy immediately. So that's an excellent strategy, and we really should be continuing to encourage folks to do that. And now we can say it will help you with your aging. If HIV itself is not enough, there are other aspects that we know that it's beneficial for. And the other thing, and this might be controversial for some people, but really aiming for 100% adherence. And I know some folks get tired and they take I'm gonna just take my weekend break. I'm gonna go on vacation and take a break and not take my meds. There's probably, and there's most likely not a consequence to your HIV because of that. You're not likely to get viremic. You're not likely to transmit HIV for those breaks in those short periods of time. But, I think that there may be a cost to aging. So Jose Castillo-Mencia did a bunch of this work. He's looked at the impact of relationship between adherence and inflammation in a whole bunch of different cohorts, US, international, and basically finds that folks that are 100% adherent have less inflammation, even compared to people that are like 95 to 100%, 95 to 99. So 100% adherence does decrease inflammation. And I don't have the slide here. This slide shows that the 0 is people that are 100% adherent, and then all of the other things are people that are like 95 to 100% adherent. He also has a study that showed that men who were 100% adherent to their meds had normalization of their markers. So many other inflammatory markers were similar to HIV seronegative persons. Go ahead.
It looks like though just a few markers,
Yeah.
right, are statistically significant. I don't know. I don't know which ones are pro-inflammatory necessarily, other than
Yeah.
the TNF alpha, but and the CRP.
CRP, IL-6, TNF alpha, So many these ones that could persistently elevated are the ones that are usually associated with
So-
increased comorbidities.
So the ones that aren't statistically significant are
These are just, they are all involved in some way, but I think for the ones that are associated with actual comorbidity and mortality, that's the big three are like CRP, IL-6, TNF alpha, and the like.
things.
So the second thing that we can do is we can cure chronic infections. And I think it's an easy sell to this group to, we should definitely be treating hepatitis C no matter what, that I think everybody is aware of. But there's actually also some benefits to inflammation. So this is a study that was looking at people who are co-infected or either mono-infected and then HIV negative, Hep C negative controls. And if you see in that fourth column, the co-infected, those folks were actually treated in that period of time. The other folks, there was no treatment for. And you could see that treatment of hepatitis C significantly decreases monocyte activation as marked by or as evaluated by CD16. And that in itself also positively impacted cognition. So the global deficit score decreased as well. So treating Hep C, we should do it not just, to end Hep C, but also to actually help the aging process of the people that we're caring for. On the other hand, CMV is another drug. I know Sarah Gianella came and talked a couple of weeks ago, I believe, about her CMV studies. But we do know that treatment of CMV, at least with valganciclovir, does decrease activated CD4 T cells, activated CD8 T cells, and actually also decrease plasma CRP. So CMV is certainly contributing to this ongoing inflammation that we see in older adults with HIV. I have two studies there that we are going to be implementing here. So 5355 is looking at a new CMV vaccine to diminish, the inflammation from CMV. And then letermovir is a new anti-CMV drug that we're going to be giving to people to see if, treating the CMV either by our own immune system by vaccinating it or using a medication that's more tolerated with the side effects than valganciclovir can actually improve these aging or immuno-accelerated markers. So the third thing we're going to talk about as far as modifying inflammation is microbial translocation. So very early on in HIV infection, the gut or the gult gets demolished because the lymphatic system of the gut is chock full of activated CD4 T cells. It has to be because it's protecting all those microbiomes in our gut from getting into our body. And the activated CD4 T cell is the type of T cell that HIV preferentially infects. So it just gets demolished. The architecture changes, fibrosis sets in, and this happens like months, just the first couple of months of HIV infection. So really early on. And we also know that microbial translocation or, like gut products that are kind of translocating across a leaky gut contribute to some of this ongoing inflammation that we see in HIV. And we've done lots of intervention studies to try to change that. We've done lots of like probiotics, prebiotics, and some other medications, and really haven't had any benefit until now, maybe. So this is a super interesting study at Croy, looking at tetraglutide, which is one of these SGLT2 agonists. It's approved, I think, it's approved for, I think, small slow gut syndrome or something of that sort, SIBO, or I forget, but it is already approved drug. And they evaluated 28 people with HIV who were suppressed on ART, randomized them to either this drug or placebo for 6 months, and then looked at what the outcome was. And I think what was really interesting is they saw that people who are on this medication had decreases in their activated monocytes, decreases in their activated CD8 T cells. But what was more interesting was that they looked at the most diseased segment of the carotid artery, and over time, people on tetraglutide had a significant decrease in the inflammatory signal in that most diseased area compared to placebo. So it looks like it is actually decreasing inflammation at areas of plaque, which is really exciting and interesting. And, I'm hoping that they take this to a larger study, but they did comment that a lot of the participants experienced pretty severe GI side effects, and they thought that that would probably be self-limiting of this approach. And yet they were hopeful that maybe novel or newer SGLT2 agonists may be better tolerated and potentially could be used to either decrease the risk of cardiovascular disease or improve the integrity of the gut. So this is interesting to me. I think that this is something to look out for. And there may be hope to actually also decreasing inflammation from this. The next part, so stress, trauma, depression, then socioeconomics. That was all aspects of HIV that also enhance aging. Some of you may not know, but it's likely all more than just psychological. Similar to people with HIV, chronically stressed or psychiatrically ill individuals are at increased risk of accumulating comorbidities. And they also have a reduced life expectancy. And when people have studied them and tried to figure out why, are folks like this not living as long and having more comorbidities, it did appear to have some links with telomere length and telomerase activity. So, without HIV, there are other cohorts like HIV that look similar and have this accelerated or accentuated aging profile. But we also know a lot more about the biology adversity. It goes beyond telomeres. So if you think about it, like stress, if you're chronically stressed, like many people living with HIV are for lots of reasons, it activates the hypothalamic pituitary adrenal cortex and the sympathetic nervous system. And the HPA axis produces glucocorticoids that causes chronic vasoconstriction, which can lead to hypertension or high blood pressure. The sympathetic nervous system releases norepinephrine, which then can result in decreases of nitric oxide and increased oxidative stress. So those are two areas that can enhance cardiovascular disease risk. But we also know that stress can alter gene expression. So there's a block of genes called the conserved transcriptional response to adversity, which is altered by all forms of stress, be it loneliness, racism, misogyny, violence. So all of these things have been evaluated and seem to impact the CTRA block of genes. And what that block of genes is it promotes the release of premature monocytes and essentially induces this pro-inflammatory milieu. So there's a lot of ways that stress itself can negatively affect inflammation and comorbidities. I'm gonna skip this, but I think I included this slide mostly to kind of talk about how that has already been demonstrated to translate into disease. So I guess I won't skip this. Women with HIV that had high psychosocial risk, which is essentially a composite score of depression, trauma, and stress, were more likely to have carotid artery plaque prevalence than women that did not have that high psychosocial risk. And when they followed these women over time, the more like the folks that had a high prevalence of high depressive symptoms were more likely to develop more plaque. So there is an association between mental health, stress, trauma with inflammation and comorbidities as well. And I although I love loneliness, I will skip this. This is a great study that basically just looked at all of these things that factor into loneliness and then loneliness's impact on people. I'll do that for another time. So one of the things I think that we have been talking about more and more is what is the impact of intersecting stigmas of aging with HIV? And so now, so at baseline, people with HIV are already dealing with their HIV stigma, and that's a big, huge one. It's not just, what they're experiencing from other people who might learn that they have HIV, but there's a lot of internalization of like, man, I don't like myself because I'm living with HIV, and I struggle with the fact that I'm living with HIV. We also know that some of them are experiencing racism. So that is another intersecting stigma, probably the primary reason why we see a lot of these differential outcomes in persons who are Black compared to white. Misogyny is a big deal, also probably a reason why we see negative outcomes for women, compared to men. But now we've got ageism. So now as our folks are aging, they're dealing with ageism, and not just ageism of the community around them, but ageism against themselves. And, this really interesting study by Charles Emlet, which was actually done a while ago. Also, he was ahead of the time, before the HIV researchers are interested, really showed that one of the things that they found when they were interviewing a lot of older adults is there was a lot of negative talk about being old, in a joking way, but they could see that there was a lot of that internalized ageism that was impacting people. And so here I want to ask everybody, you don't have to tell me, but I want to know who is 100% over HIV stigma? You don't have to, just ask yourself in your head and answer in your head. So I don't want to call anybody out. So think about that. Are you truly over your own HIV stigma, whether it be towards others or yourself, whoever's on the line? And the second question is, are you truly over ageism? Are you asking your older adults if they're having sex? Are you asking your older adults if they're using drugs? How do you view your older adults? Do you value them? So this is something that's not just impacting people with HIV. It is impacting providers in the healthcare system. It's impacting providers in the service area. And I think it's something we need to be talking about. Anyone want to make a comment? You don't have to share, but I'd love to hear if anyone has a comment, either here or remotely about intersecting stigmas.
I was just going to say very briefly, this is a fabulous Venn diagram. The things I would add, because yes, this was a while ago.
Yeah.
So in addition to homophobia, which I think is huge, I would also say transphobia, and then those aspects internalized. So internalized homophobia, internalized transphobia, which are, very predominant for folks living with HIV.
Yeah. And I'm actually running out of time, so I'm gonna.
I was about to give you the 8:40 warning.
So I'm going to go through some of these things. So just briefly mention these. I'm so sorry, everybody. So, another part of stress for people living with HIV or older adults is really uncertainty around aging. They don't know who's going to take care of them. They're worried about their finances. I just looked today about what the maximum Social Security per month is right now for 2022, and it's something like $841 a month, which is ridiculous. So that is also contributing to a lot of stress. This slide, and again, I apologize, guys. This slide basically just shows that people with HIV have poorer quality diets. It's gray here compared to people without HIV. Women with HIV, gray down here, compared to men with HIV, have even worse quality diets. And the quality of your diet, if you had a poor quality diet, you were more likely to have more inflammation. So, even things like diet is contributing to, the inflammation and comorbidity that people with HIV are experiencing. So I've talked now up to this point about the Gero drivers, and I've hopefully given folks some tools or ideas of ways that we can start to lift the impact of HIV off of aging. And I'm going to end in the next 4 minutes on the geroprotectors. These things I think are more intuitive, so hopefully people will not mind that I'm going to fly through the slides. So exercise, I think everybody knows it's good for you. Certainly, though, it does decrease inflammation. This work by Christine Erlandson showed that people with HIV had decreases in their CRP, which is another classic inflammatory marker, but only if they were participating in a high intensity exercise regimen, not moderate intensity. So that wasn't enough. So it seems like the more that you can do and the more you can tolerate, the better as far as exercise goes. This study from Croy was really interesting because they actually put men through strength training for 6 months and found that folks that had the greater increase or the greatest increases in their strength had larger brain volumes, increases in executive function, and decreased inflammation. So exercise of different forms seems to be beneficial. And then I wanted to kind of take a break here and talk a little bit about resilience. I think resilience is one of those terms that everybody kind of knows what it is, but doesn't really know what it is. Certainly in this table shows that in a community of Black people living with HIV in the South, resilience was highly protective for quality of life. What do you guys define resilience as? I'd love to hear that. What do you guys, when you think of resilience, what pops in your head? And I can repeat, as people are saying, if anybody wants to say. I'm not hearing anything. Do you guys? Ability to bounce back from adversity. Absolutely, that's great. Anyone have any other thoughts? Rubber band. Yeah, similar. Ability to bounce back from adversity. Strength to keep going. Yes. And so when we've asked, we meaning the community of researchers, not me, what resilience means to people with HIV, these are the things that they felt were tools for them that has helped them to be resilient. So accepting their limitations, like, okay, I can't do this anymore. It's okay. Like just being accepting of that, having an optimistic attitude towards life. Maintenance of social support was a big thing that a lot of people with HIV said contributed to their resilience. Taking responsibility for myself, not blaming others, but like, I'm the one that gets in the way. I'm going to take responsibility and change that. Living a healthy lifestyle, and then engaging in meaningful activities. And another study, broke that down to very similar things. Being, belonging, believing, and benevolence. They felt all contributed to resilience. So what I'd like to propose.
Maile, just to,
yeah.
So, few people. So ability to persist, ability to withstand repeated and sustained adversity. And then Kathy Promer says we need a fitness coach.
I agree, Kathy. I'm trying to get a grant for that. I think we talk a lot about trauma-informed care, and 100% that is absolutely necessary for HIV care. But I want to challenge us all and say it's just the beginning. So, trauma-informed care, or the systems to do no harm, is just the beginning of how we help our older adults age well, or even our younger adults age well. Resilience is more than that. And I'm not, so these are just basically, principles of resilience. Sorry. I don't know how to get rid of that. That I'm not going to go through, but I am going to go through on my next slide. So as I was thinking about, like, how do we do this? Yeah, it's great to talk about the principles, but how do we actually do this? So I kind of came up with action items, 4 things to we need to be normalizing, engaging, implementing, and advocating. These are the 4 things I think are really key. And I want feedback on this. I want to know what I'm missing. And we need to do that across the biologic, psychologic, and social aspects of the lives of people living with HIV. So as far as biologic, we really need to normalize mental health, behavioral health, and treatments. A lot of people don't seek it out because our society has a negative stigma against it. And that's something that we need to totally normalize for people. Psychologically, similarly with psychological. And then we also need to normalize needing human connection. We have this culture that praises independence. I can do it myself. I'm strong. I do it on my own. Okay, great. Good for you. But it doesn't mean you don't need social connection still. That is a key part of being a human. We also need to be engaging our psychiatrists, as well as our psychologists and therapists and other trained lay personnel to be implementing these things. And I think we need to build up our peer navigators and do more with our community-based organizations. We tend to be siloed in clinics, mostly because, we don't have all of the funding to have all those things in-house, but there are some amazing organizations around us that are doing wonderful work, and we need to be more engaged with them. As far as implementation, we need to start treating intersectionalities. And I think we are doing that at Owen. We're definitely ramping up our substance use treatment services, including MAT. I'd love for us to be able to ramp up our mental health services. I think we're also trying to do that, but we have a mental health crisis. We just don't have enough providers in the US. I think we should be implementing more behavioral therapy. I'd love to implement more mindfulness. Dan, I'm looking at you. As well as having opportunities for, our patients and our staff to do skills building around, positive coping, emotional regulation, and self-efficacy. And then socially, we should be giving social prescriptions, but, we can only do that if we have a place for people to go. So again, being aware of what the community is offering and where folks can fit, helping to put together support and affinity groups. And some folks, have not talked to a lot of people, at least for 2 years, and they may need some help with interpersonal skills building. And also we need to just develop social capital around our community. And lastly, I think as clinicians, probably we more than anyone else, and maybe also the geriatricians, are advocates for our folks. And that's something that we still need to keep doing. One of the things the community says a lot is that, supportive services are essential services. Like housing are essential. It's not supportive. Like we don't have housing. We need housing. Food is essential. It's not supportive. We need to advocate for expanded services and co-location. So, like, great, we have psychiatrists and we have case managers and social workers in our clinic. Maybe we need a cardiologist. Maybe we need physical therapy. And we should be trying to advocate for that. And then, enhancement or greater community level resources for our folks as well. And then I'm going to skip these. It basically just shows that like, if you don't get good sleep, it's not good. So we should be helping our patients sleep. I think we all know about that. And then I'm going to skip the geroprotective compounds. Just briefly, to be included as a geroprotective compound, you need to either be a senolytic, which means you decrease or you decrease death or you enhance like the lifespan of things, or a xenomorphic, meaning you are in somehow altering the way that cells are aging. Metformin is not classically a geroprotective compound, but has a lot of positive outcomes. And I think that we keep looking at it to see, is it beneficial beyond, diabetes, basically. This slide is a senolytic. So dasatinib for certain is a senolytic that was evaluated from blood that was pulled out of people with HIV and HIV negatives. It does seem to demonstrate benefit in decreasing activated T cells. So this is potentially a future study. It's the reason that they did it in blood pulled out of people and not in people is because it's still fairly toxic. So we are trying to figure out a way to develop senolytics and provide it to people so that it's safe and actually effective. But this, I think, is where a lot of our future HIV studies are likely going to be going, at least as it relates to aging. Okay, and then we talked about all these things, and that's it. So thank you. Any questions? So sorry, I'm 5 minutes over. I tried.
No one knows about the new plan yet.
Okay.
So that's internal. Do people in the room have comments? There are things from the chat that some I will read and some I will ask people to unmute themselves. Anyone in the room though? Let's give the Zoomers. I like that word. Nettie, would you like to unmute yourself? You've had a few comments throughout.
Sure. Great talk, Maile. That was wonderful. Thank you. I, at the beginning, mentioned the stigma, but then you devoted a bunch of slides to it, so that's great. And then I also thought that the regimen conversation was really important. And I wanted to remind us never to criticize a patient's regimen. I'm sure everyone has had this experience where you have a carefully selected regimen because the patient had a negative outcome on something else, and you're managing their meds based on their comorbidities and blah, blah. And then they bump into someone else in the healthcare environment who says, oh, you should really be on this. And it kind of undermines their faith in their meds. So I do believe in personalizing medicine. And then I had a long-winded comment about how we laugh at the idea of having a fitness coach. But, we laugh because we know it's like, we won't get funding for it. But, the things that work for aging and for everything else are diet and healthy food and access to healthy food and exercise. So if only we had better advocacy to our funders to explain to them that their money would be well spent that way.
We have excellent advocacy. It's people aren't listening. Like our community of older adults is incredibly active and they're amazing, but people are not listening to them.
Well, I'm not criticizing them, but then that's not advocacy. Like that I'm talking about us. Like all of us, our hospitals, our health centers, our doctors, all of us. So we have advocates, but we're not being effective. And so that's on us, but that's on our funders. They're not looking at the data. They're going, well, it's easier to cover meds, or they don't have a holistic approach to medicine because of our fragmented healthcare system, which again goes back to, the whole country advocacy.
Yeah, run for president, Nettie. I'll vote for you.
What an awful job. No, I don't want the job.
Who will continue to help carry out services and Connie said something fairly similar. It's very helpful at faculty, clinician development training for us to patients provided with better tools to address some of these issues?
So we did write a grant that wanted to do that, and we didn't get it, unfortunately. But one of the things I think that we have prioritized is identifying champions. So folks we know that actually like taking care of our patients and are kind, and offering to them opportunities to get more education around HIV and, trauma-informed care, resilience-focused care, so that our folks actually want to go and see people other than us. I think we all know it's hard sometimes to get folks to specialists because they have a bad experience and then they don't want to go see anyone else. But I think we can identify champions within our systems who, will have a good experience with. And I think that should be a priority going forward.
Then there's just some praise for you and your talk. I don't know if anyone else wants to add something here or unmute yourself on the chat, or sorry, unmute yourself on Zoom. Daniel.
I swear I am not a plant asking questions. But you talked a little bit about the trying to close the comorbidity gap in people with HIV. I guess the simple question is, do you really think that that can be closed, in the sense that if there is some disease or infection like HIV, or you could put any other infection, doesn't that by definition automatically increase inflammation, and therefore the gap will never be closed?
So I think it will never be closed. I think we can narrow it. I think similar to the lifespan gap, I'm hoping we can close that. I actually do think, so what we don't know is all of these younger folks, the 20-year-olds in the last decade or so that were started on ART, like 2 months after they were infected, because they test all the time, and have been on ART and, live a healthy lifestyle, are actively working, good social life. I'm hoping that they will start to close the gap. But it's comes down to the health disparities, right? It comes down to folks that can't do that for whatever reason, cannot be functioning normally, are regularly experiencing disparities, can access care, have lots and lots of stigma, doesn't have anyone to talk to about their HIV. That's, I think, where we need to continue to be working on, because it's that group of folks that, time and time again keep popping up as having more and more or worse outcomes, that I think we can start to change some of those things.
Second question, do you think it's difficult to motivate or inspire patients using the argument to prevent aging?
So it is for younger people, because they don't think of it, because it's hard for them to see themselves that way. So one of the things that I've also tried to do is implement intergenerational relationships, not, like friendships basically, or even like a mentorship type thing. It's one of the things that we wanted to do at the village, but then unfortunately, because of COVID, they couldn't accept any volunteers and we couldn't get any younger people into the village. But, there's a lot of our older adults, and especially our long-term survivors, are crazy resilient. And they have so many things to offer to younger folks, and even though younger folks may not see that, I think as those relationships are developed, it will become clear.
Great, thank you.
Sure. I think we're done. Hard stop, Jill? Okay.
Hard stop, everyone. We're trying. We want to give you time to get to your next things.
Thanks, everybody.
Maile, thank you so much. This was great. See everyone next week.